core group here, but anybody who's new to the group, this is casual. We're just chatting about everything LAL, trying to learn collectively. I mean, I feel like we've got the most collective experience probably in the country between, the five of us core people here and then everybody else. So um, this is casual, no agenda. I do have a case. I'd love to share and I guess hear you guys' feedback if you want, or if anybody else has anything that they want to talk about, we can start there. Nobody? All right, I'll start
Uh,
with my.
I have
Yeah,
a
go ahead, Jess.
question.
Yeah.
So I don't know if RxSites reached out about, when you guys have bubbles in your treatment area,
hmm
how diligent are you on like reapplying the gel and where and in the type of treatments? Just curious. You
I mean,
leave a few tiny ones there,
I do the best I can, but some people like it's impossible. I think
right?
I find that if I have to reapply the lens more than twice, I just deal with it.
Yeah.
Mhm. Are
Well,
you guys all using Genteel or are you doing some other type of gel or drop?
depends if it's in stock,
Yeah.
Right.
Yeah.
I've adapted to anything I can get.
right?
Yeah.
Every year they go out of stock. It's like, come on. I mean, it's going to go out of stock. Why can't they amp up production so that doesn't just disappear for 5 months?
I mean,
Yeah.
yeah, I feel like the LAL has like just driven the demand for Genteel up like significant. It has to, right? Like that's
Yeah.
the best. At least in my experience, it is.
Is anybody else using anything else other than Gen 2?
Yeah.
We're currently using Celluvisc.
Celluvis?
Only problem with Celluvis is I find that it slips out a lot.
Yeah.
Right when you put it on, you're like,
Yeah.
it just like pops out. So I got really frustrated with it. But yeah,
It's
we had to
true.
use that for a while too.
We're just
Was
using Refresh Gel even, and that seems
No.
Genteel used to drive me nuts with all the bubbles, but now with the gel, it's not a big deal.
Cystane has another gel as well, or they're supposed to be the same thing. I mean, there is the
Yeah.
same
So
Yeah.
company now,
yeah.
but sometimes you can't get a hold of that either.
Yeah.
So I brought up the bubbles just as a heads up because I used to think, okay, well, if it's in the periphery, I don't care about it. However, we were viewing some cases, and just to know, when you're doing your lock-ins, you do care about the periphery more
Mhm.
than anything else because it really blasts the periphery. So those are the times you really want to squeeze it out of that area because it could potentially cause problems post lock-in, like regression or just aberrations in their vision. So that's just something new that I'm like, okay, well, I didn't care about it before, but I'm just more
Yeah.
um
Yeah, I didn't worry
diligent.
about it in the periphery, if it was
Yeah,
out past the capsular rhexis, I didn't worry about it.
right.
But
Yeah.
during a
So like
lock-in, it
just
should, huh?
yeah, push those all out if possible. And I found too, if you put a lot of pressure on, they don't feel it. It squeezes that bubble out of there in that direction and you're good to go.
Yeah,
I
I
call
think that
myself the
comes with
bubble
a
whisperer because I can flip those
yeah.
suckers over.
That
Mhm.
comes with experience. No, that certainly does. I feel like you get better at like learning how to manipulate the bubbles over
Yeah.
time and
Mhm.
doing it. Yeah, that's a good point, Jenny. I think after like the lock-in are where I am the biggest, both lock-ins, especially the last one, the biggest stickler about bubbles and pupil size, just because you want to get the entirety of the lens as much as possible. But I mean, some people it's like riding a bucking bronco where they're just like moving around. I
Yeah.
don't know. There's diminishing returns, I think, to being too, picky about it, but you're right. I mean, do the best you can.
Speaking of lock-ins, those are sometimes the hardest ones for patients to sit still because of the intensity of the light. Do you guys
Hmm.
have any like tricks or tips for the people that are harder to hold still or have just a harder time with the brightness of the lock-ins?
Do you have like soothing spa music in your LDD room? We
We
started
have
playing that on a computer.
okay, soothing spa music. We've talked, we'll sometimes ask the patient if they have a song request, we'll play that. We've done like stress balls.
Yeah.
I'll try to distract them by like telling them to like wiggle their toes or focusing on the breathing, or like just things to distract them. But I mean, I've had some patients where I've had to give them like a relaxant prior to even doing the
Oh, yeah.
treatment.
Yeah.
Or the countdown. The patients say they really like if you
Oh,
could
yeah.
just let them, okay, you're already at 80 seconds, you're doing great. And then every like 10 to 15 seconds, give them another update and lifting up and just let them break for a second and just give them 6 seconds and be like, okay, we're going to go again. So we chip away at it with the patients that really are squeezing tight and not letting you get through it.
Yeah.
But
We play
constant
music.
chatter.
Yeah, we play music, and we I have a tech who discovered she can pat their shoulder, or there's just there's a gentle rhythm that she does for some of those folks, and it's actually proven really effective.
Oh,
That's a good idea. Yeah.
Get patient consent.
That's why I said
Oh,
shoulder.
yeah.
Just pat the shoulder.
We started using essential oils too to help calm them. So lavender helps calm them. We use peppermint.
Huh.
And they've commented on it feels really relaxing when they walk into that room and the lights are dim for them. They hear the music, and then it's just like a little less stressful.
Music, I definitely do. I mean, we play music
Yep.
all the time, and I try to read the patient too. I mean, if it's like the rough biker type, it's AC/DC. If it's a 85-year-old grandma, then we'll play some whatever. Um, we have a smart speaker. Funny story, and maybe I've told this before, but it's connected to my personal Spotify account, which is dangerous. And I work out every morning, and the stuff that I listen to in the gym is not necessarily clinic appropriate. So I walk into my first adjustment, it's like 8:45 in the morning, and hey Alexa, play whatever. And it puts on like hardcore Eminem, which is like and like really loud too. And I'm like, oh my God. And thankfully the patient was a good sport. She started cracking up, like, oh my God, that's not normally what I play. Normally it's like, violin or whatever, some instrumental. It was pretty funny. But yeah, so word to the wise, be careful with that.
I feel
Yeah.
like it's a great idea though, distract them and maybe just asking the patient what their song requests are. So I will say I had ArcSight give me one tip that I think has really helped is sometimes patients that dilate really big are more light sensitive. Obviously, there's more light going to the back of the eye. So she was telling me to bring a patient in as soon as they're dilated just big enough as the lens and try not to have them dilate bigger than that. And so I had a patient who's like dilating to like a 9 every time. And just the clinic flow, I wouldn't see her until she was a 9 in the treatment room. And then I decided bring her right in as soon as she's at like a 7 or 6.5. And they brought her in and she was like, that was so much better. And it was the second lock in, but I do think that made a difference for us too.
That's a good strategy.
Yeah.
I have a question too for you guys, more on the patient experience, kind of the dilation thing. Something that we've started using pretty regularly is Rezumvi. Have you guys dabbled with Rezumvi?
We
Yeah.
experimented with it.
Yeah. Thoughts?
Um, for us, I mean, about half the patients are like, "Oh, that was great," and the other half are like, "Meh."
Yeah.
So
How much is it? Do we know?
It's like
Just
$10 or something, isn't it?
oh, really? I would have
Yeah.
expected because the other one is super expensive, the other reversal.
It's like I can't
$10 a
remember.
vial or something, I think.
Yeah, it's not particularly cheap. However, off-label, you can get like several drops out of each vial, which I
Right.
I do repurpose. I
Oh,
usually get
I
about
thought it was
six.
like a big bottle we're talking
No,
about.
No, it's a little
no,
like
it's per application technically, but like
That
you
makes
said, you
sense.
can get, yeah, we definitely offer it to our patients. I know it's, whatever added cost, but $10 for their experience to be better, I think is well worth it.
yeah. When it came out, like was it like a year ago or so, I was pretty lukewarm about it. I tried it on my own eyes, which probably was not a fair comparison because I'm just tolerant to the dilation. I did one eye with it, one eye without it after dilating both eyes, and I didn't notice much of a difference. One of my eyes, the eye that I used, the Resume V, did get very red. But then
Yeah.
I gave it a fair shot with a handful of patients. Some were really into it, some were not so much. And I've recently decided just to offer it to everybody. More often than not, patients are coming back saying they love it, that it actually does make a difference, which is, is there some placebo effect? Maybe. Does it actually cut the dilation down? I do believe that it cuts the dilation down at least like in half. It doesn't take it away. It'd be nice if it took it away immediately. That's the holy grail, I think, is the reversal that happens right away. But it cuts it in half. And for people, especially these patients who are young and a lot of them are still working, it makes a difference. So yeah, there's a cost to it, but it's peanuts, and you could bake it into the cost if it really matters, just for the experience. But patients have liked it, and we've started doing it pretty routinely. Just a thought. Yeah. So I do want to share my case because this is kind of along the lines of people. Um, Here, let me share my screen here quick. All right, you guys see it?
Mhm.
Yeah.
Mhm.
Okay. So real quick case. This is a 69-year-old white female. Um, Routine. I mean, everything about her is pretty routine. She's a moderate myo. Corneas look normal. Maculas are normal. Really nothing going on. Um, we went through surgery, and this is where she was at the day of her first visit. So refractively, again, nothing alarming. This is kind of where we want them to be, just a little bit hyperopic, maybe a little more on the right eye than the left. Overall, doing good. I noted in on this visit that the lens was decentered. It was kind of inferiorly decentered. It looked like the haptic was outside of the bag, like the superior haptic was a little bit outside of the bag. And um, I was that obviously caught my attention, but she wasn't complaining, and she was correctable to 2015. I really only saw that when she was fully dilated, so I didn't think anything of it. Um, we ended up doing a little bit of a blend. Her right eye, where the lens was decentered, she was Plano 2015. Ended up targeting left eye to -1.25. She came back a week later, really at target, but now she's developing PCO, and it's there. It's visually significant, both eyes. She's complaining of glare more and more and more. And so, I'm thinking, and I had my surgeon take a look too, and I wanted his honest opinion. Is the complaint be, is the complaint because of the PCO, or is it because of the decentered lens? And because she was complaining more and more, we deduced that it was more PCO related. It wasn't because the lens was decentered. We were debating on, do we want to go back and just restart this whole process, put the lens back in the bag, make sure that it's centered, or just proceed? And we decided to do the YAG. So I took a picture of it. It's a beautiful picture that I took at the slit lamp. That's what it looked like. She's got beautiful eyes. She's got a whole 7 eyelashes there, but it's about that much decentered when she's dilated. And you can't see the haptic in this wonderful photograph, but it's outside of the bag. So I'm curious about your guys' opinion here. What would you do, or what are your thoughts about a lens that's decentered, but the patient's really complaining only when they're really dilated? And then what are your considerations to proceed with a YAG versus basically do an explant and reposition it? Because you'd have to restart over, right?
I don't think so, Nick. I think you could refloat that lens and put the haptic back in the bag. Recenter the lens. I would be a little leery of breaching that capsule if you have to potentially maneuver that lens at some other point. Just a thought that so again, going back in and refloating it, putting it back in the bag, realigning it, and don't touch the capsule initially. Because was the PCO similar between the two eyes, but you had more complaints in the right?
It was similar between the two, more complaints on the right.
Did
So
you
my,
did you
yeah.
look at like total aberrations of the eye at all to see? I know you have the Pentacam.
Hmm.
If there was a difference, I don't know. I don't know if you look at that at all, but I'd be kind of curious. Sometimes with tilt or decentered lenses, you're going to induce more aberrations.
Yeah, I definitely did. We have a waveguide aberrometer. I looked at it. I mean, they were pretty comparable between the two. And I didn't put that in here. I didn't have enough time to actually get the scan, but I remember the data being very similar.
Yeah.
And it wasn't, again, that was kind of supporting the idea that it was mostly PCO, I thought.
Mhm.
Um, but this was, let me look back at my timeline here. I think the YAG that we did end up doing was post lock-in. So
Oh,
the concern with repositioning the lens is we've already adjusted the lens to match its effective lens position. So if you move it
Hmm.
even a half a millimeter, you're going to change the refractive outcome in what
mhm.
is her plano set eye. If this were her reading eye, I would be a little bit more, you know, okay with the idea of going back. But being that it's her distance eye, any deviation from the effective lens position is going to cause a refractive shift.
So she's had her final lock-in already,
Yes. So
and
by
her
the time
overall
we,
vision undilated, you said, is pretty crisp and clear, and she's pretty happy with it.
yes, a normal ambient lighting, she's comfortable, especially after the YAG. So we did the YAG and she was happy.
Mhm.
However, so here's where things get a little bit fuzzy. Actually, so here, never mind. I take that back. This is pre-YAG, Plano -1. This is post-YAG. She's minus a quarter now, plus 75. So the YAG, I think, ended up tilting the lens more. And now she's complaining a lot more. So she's happy during the day, significant glare at nighttime, really hard to drive. Left eye is stable. She says that the YAG did help, but at the same time, it made it worse because, again, I think the lens shifted when we did the YAG. Um, so thought this was she saw a different one of our doctors in our clinic on this day, and the thought I think was correct. Starting Viz. Have you guys had any success with Viz or Closey?
I literally had one today that
Mhm.
we used Viz for her night driving because we had yagged. She was locked in, but she was experiencing some strange photopsia we just couldn't explain. She's Plano, and the Viz took care of it.
Hmm.
It
Anybody else?
I'm a firm believer of using one of those drugs, for nighttime aberration issues for sure. Very beneficial.
Yeah, I've dabbled with both. I've had more success, a bit more experience, at least with Closey. Viz is stronger. I mean, Viz definitely gets you a smaller pupil. I think in particular with the LAL plus, I mean, you make the pupil really small, you're going to catch more of that aspheric zone. As long as the lens is centered, you probably will have a benefit of extending range of vision a little bit more. Um, Closey, a little bit less strong. You know, the theory with the pupil size, I mean, the smaller you go, there's not necessarily benefit. At some point, there could be diminishing return. You get contrast loss. And I think Viz walks that line a little closer. Closely, I think, works really well, especially for patients who need just a little bit extra. You know, if they're like really close to being able to see everything they want. Because if anything, I mean, when we do the treatments, when I do the treatments at least, I want to get the distance, get as much of their functionality as possible. But if we're going to leave something on the table, it's the small stuff, right? I mean, laws of physics, I don't want to push too far to really throw off their distance. I've found that closely tends to be a little bit better. Um, but for the right individual, I think there's room in the sandbox for both. They do different things. So with this one, and the theory I think makes sense with what my colleague did. I mean, we want a small pupil because now we're thinking that the decentration of the lens is really the problem. Unfortunately, we did the YAG, and so now the idea of going back in becomes a lot more complicated, which we're really trying to avoid. So Viz makes sense. And so she got that, and then she only used it one time, and she developed a brown dot in her left eye now, which is a bummer, and that spooked her, obviously. So I'm seeing her here. This is a month later. She's only used Viz one time, and we do a quick scan, and you can see right there, there's VMT on her left eye. That was not there before. So, is that because of Viz? Is it just coincidental? Anybody have any thoughts? I really don't know. I mean, I think, there's going to be some pulling mechanism. It could have induced the traction a little bit more that wasn't there before.
Would that
That
be
could have
less likely with the Qlosi?
less likely, Steve.
Yeah, would it be less likely with the Qlosi? Because it's not, doesn't stimulate the muscles as much.
I don't know. I mean, the thing with Viz is that it's ciliary sparing. That's the difference between the two. So I almost think that Viz wouldn't have as much traction. I don't really know. I don't know if this was something that was unintentionally caused by the drug or if this was a coincidental thing that was going to happen no matter what. Either way, I mean, with any of these drugs, because they are constrictors, if you see something like this, general recommendation is to stop it. So we did. I put her on brimonidine, which is the old school trick in refractive surgery. Brimonidine doesn't constrict the pupil, it just stops it from dilating. And that fixed her problem. She's happy. I've talked to her several times since this visit just to check in because this was a case that really had my attention. And she's doing really well. She uses the brimonidine about an hour before she drives. And I've talked to her about, yeah, there are surgical options that we can pursue. However, they do come with substantial risk. And you know, the lower end of the risk profile is, well, we have to exchange the lens and now redo the entire process. The higher end is vitreous prolapse, retinal detachments, all that stuff. Those are all very, very real. So I'm, I think a lot of surgeons would probably be pretty hesitant to go back in with an open capsule. But yeah, I don't know. It's an interesting case. It's an interesting
I mean,
case.
I have a couple comments,
Yeah.
Nick, and that I don't know if you can ascertain whether that VMT is from the viz or just, after having cataract surgery and just the vitreoretinal dynamics, the change.
Hmm.
So for her left eye, but the right eye, we did have our first explant several months ago for LAL. She just had persistent glare, and we yagged her, and we just weren't sure what to do, what the cause of it was. We just wasn't making a whole lot of sense. But the LAL, the beauty is you can then put the lens in the sulcus, for the second round is what we did. And so she's much happier now. So we don't know if it was an issue with the implant or what, because everything looked good, with her aberrometry and what have you. But she was definitely not a happy camper. So that's something to keep in mind too, if she ever does have further problems, because those decentered lenses can certainly become more decentered over time. And if ever you have to explant it, to go in the sulcus is a nice option, and then just restart the process.
It's a good point. Yeah, we've done lenses in the sulcus before. Broken bags during surgery, things like that. Things can happen. And it works fine. So that is on the table with this patient. Getting the lens out, I know can be kind of tricky. The lens, from what I've never taken one out, obviously, but from what I've heard or how I understand it, it's kind of brittle like a cracker, where it kind of can fall apart, and it's not like taking out a different acrylic lens where it comes out softly.
Yeah, typically, I guess they do recommend removing it prior to lock-ins, but
Hmm.
yeah.
Just from the group knowledge, I wanted to ask a question. I've got an orthopedic surgeon who I just
Mhm.
spoke to the referring optometrist who said that this guy comes back three pair of glasses. And I wonder how much plus I can get out of two L's without changing his binocularity up close. You know what I'm saying? How much can I tell him he can get? Intermediate, and then he has to put on surgical scopes for the fine detail.
That's usually how I set the expectation. I mean, anybody in the medical field, I tell them that if you normally would use loops with contacts on, then I still expect you to need them because those will magnify things, and you're not going to replace the effect of magnification. But for an orthopedic, it depends on what kind of orthopedics they're doing. Are they hammering knee implants or are they doing, metacarpals? There's a difference in that too. So I guess it depends on how you set that stage.
I don't know. I mean, I spoke to the referring optometrist this afternoon. We had actually met at a meeting about 3 months ago, which was kind of weird. Which is why he referred to me, I think. But that's what I want to discuss with the patient. He's coming in Monday. So
So he's a bilateral LAL, you said, or LAL plus?
LAL.
LAL. I mean, you should, and he hasn't had any adjustments, you said, Steve?
I haven't seen him. I haven't evaluated him yet. So no, he has no
Got
adjustments at this point.
Gotcha. Yeah, I mean, they should be functional. That's what I tell people. By the end of this whole thing, this should be functional. I think with the plus, especially if this were a plus patient or just in general, I guess going to your point a little bit ago, Jess, with how myopic do you go with the plus? Patients who are at like that high end threshold for me, which is like -1 with an LAL plus, if they're still wanting more reading, that's where I take my foot off the gas and just don't do anything. I give them more neuroadaptation time. I do think neuroadaptation is real, or
Mhm.
patients just start to understand. I mean, whether it's real or if it's just they start getting used to the new normal, however you want to put it, it helps. So when patients are still wanting more and more and more, and I'm in control, I want to give them more. I want to make this patient happy, but going from -1 to -2 is only going to make things worse. I know that because the NISO. Give them a couple weeks. Usually I'll kick them out for a week or two at least and bring them back. And more often than not, they come back and they've adapted and they've realized, oh, actually, I can see better than I thought. Right. Exactly. Just my 2 cents for those patients.
How high of
Mhm.
a plus would you do for straight LALs in a monovision situation? So would you do a 150?
Rarely, I mean, has he done monovision before?
I can't answer.
If
I
they
mean, I can have
have,
them try it with contacts. That shouldn't be a big issue.
you could. I mean, I know maybe we can talk about that a little bit. How often do you guys do contact lens trials? Some of us maybe more than others.
I do it a lot. Anybody that's worn contacts before, I will have them try it out for a week with, plus 50, +1, +150, just to see what they think about the monovision concept. So I'm throwing away a number of tries.
I don't hesitate to use them if I'm going outside my, normal comfort range. I'm like, okay, we need to step a little more than I would normally do. Let's try this in a lens first, and I'll send them home with a contact lens to try it.
I find that it lengthens the time period that we're doing the adjustment of it. But I found that just about every single person at the end of it has been extremely happy. I mean, that we're talking 9, 10 people, not compared to what you guys do.
Yeah, I think Ken, I'm with you. I only use it when it's outside of my norm, and it's usually only on the third treatment when we
Mhm.
only have one more shot left.
Hmm.
But I have been burned in the past too many times by trying contact lenses, and patients come back and they complain about the fit of the lens, not necessarily the vision. And too many times. I mean, like those complaints where you just want to bang your head against the door. Like, okay, it's not the point.
Right.
And now
Well,
you're talking about their dry eye issues, and
Clear
you're
to
talking about
communicate here. You're not getting
yes. And I always feel that I am very clear when I talk about this, and I say, Mrs. Smith, do not come and complain about the fit of the contact. Do not complain about how it feels. I don't care. I care about how you can see. Yeah, well, it just feels kind of weird. Like, yes, I know it feels kind of weird. This is foreign to you. You've never had a okay. So only when it's out of my normal comfort zone, only on the third treatment do I ever pull one out. It's not often. It maybe once a month. It's really not often for me. But
Uh, we,
if
we probably do a little more contacts than I would say most of you. I'm especially in their, the psychology of these folks before they get their lock in. They're always wondering if they can get a little more near vision, and so might throw a +50 on. But like you said, Nick, it's always when you're done adjusting and you're getting ready to lock in. Seems to be the time when we trial those. But
yeah, there's a psychological component to that too. I mean, Ron, like these patients do, I think at the end of the day, want control. I mean, that's what everybody wants. And this is the beautiful part about the technology is they get the control. This just kind of delays that finality process. I think the finality of the final lock is sometimes daunting for people. They're like, oh my God. And I always try to remind them that you would never had this decision anyways if you had gone with any other lens. These conversations would have been completely hypothetical. You'd never have them. But we have the ability to have this. So don't get focused on the hypothetical, or not the hypothetical, but the reality of the finality of this. Be thankful that we're here and we've made it to the end of this journey and you're doing great. And if they just need more time, again, that's where I just take my foot off the gas and say, go home, think about it. That's fine.
yeah, I just think it kind of lets them make that final decision, because they
Mhm.
always have that what if, and so if you put a +50 on and say go home, see how it affects your distance, how it affects your near, then when they come back, then, then they're kind of making that final decision like, yeah, okay, you're right. I was better before, or you know what, I do want this little extra, kind of thing. So, but yeah.
Yeah, I like using on those patients too, the ones that are questioning every single adjustment that you do. And they're like, I gotta know if there's something better. Like just for them to be able to see, it's sometimes those ones that you're so frustrated that you're like, I know that another one is not, it's gonna take away too much of your distance. I know you want that more near, but you're still gonna need light pair readers and dim lighting when you're reading a coupon in a garage at night. And so I'm like, this one more adjustment still isn't gonna cut it. But those are the patients that I'm like, okay, we'll set you up with your referring doctor. We'll get you some contact lens trials. And then sure enough, they come back and they're like, yeah, I still need that reader in the dim lighting. So I do think that's when I try to pull it out of my pocket because I feel like if you do it too much, sometimes the patients can overthink also, and
Yeah.
it can lead to more issues with the fit of the contacts, like dry eye, and just delay the process so much that you're having to work with them for months. So yeah, I agree with you guys on just kind of using it as like a last resort, just to make the patient feel more comfortable. And one thing too, with like the permanency of the lock-in, that I'll kind of help patients if they're at the point where I think they're doing well and they're still hesitant. I'll be like, either you can take another week if you want to just sit in this and think about it and just come back next week. We can start the lock in next time. So I'll let them know that, or the contact lens trial, or the other thing I'll mention too is that this isn't in the end all. If say we locked in and you didn't like the setup down the road, but and I always say I don't think that's going to happen, but if that happened, you could still get LASIK or PRK in the future. And I hate to advertise that, but it's something that we do offer for our patients who get advanced technology. If they're unhappy with their outcome for a year after surgery, they get LASIK or PRK at no extra cost. And I always tell them that that's less than 0.5% of our light adjustable lens patients. So it's very rare. But sometimes these patients that are overthinking and really want to be involved in their outcome and they're nervous, those few points can kind of help them get through the lock-in process.
Or even just glasses. I mean, some
Yeah.
patients still like, well, could I like get glasses? Like, yeah, you of course. I'm sorry. Yes, I'm like overcomplicating this. Yes, you could get glasses for those tasks, like driving at nighttime in the rain. Like, yeah, you might want a
Right.
little bit of help. And we haven't even
Hmm.
talked about that because I'm so sensitive to the no glasses idea, assuming that is the only thing they want. But they want that. I think it's important to sometimes simplify it a little bit. Yes, you can get glasses for those types of things. I got a question for everybody. I think RxSight has changed the messaging a little bit with the dominant eye targeting. What do you guys target the dominant eye? Plano, or do you target something different?
I target Plano.
Plano, maybe a quarter plus.
I'm pretty much all plus a quarter now. I
Yeah.
found that there's zero compromise to anything by targeting plus a quarter. It compensates for any residual shift. I mean,
Mhm.
there's not a lot of shift, but if there is a shift, it's generally in the myopic direction. I found zero harm doing that probably over the last 6 months or so. And they don't feel any more anti-ISO than they normally would. Um, so Joe, you've been doing that too?
Yeah, I've been doing that from the very beginning. It seemed to
Hmm.
work. I have short rooms too, and I think a lot of us will do, have a
Yep.
short room, but I will constantly do plus a quarter, and then I usually check between like Plano and plus 50. And ideally for me, I want them to say the plus 50 is better than the Plano. And then I just never get myopic shifts, and I rarely ever have an issue. And they prefer it much better when they're looking out the window further away for their task. And myopic shifts, I think, at the beginning for a lot of people is a problem because they're trying to figure out why is this patient having, like, they're telling us that they're on top of a street sign before they can see it. I hate hearing that post a lock-in, but when you target plus a quarter and a little bit further out, then you don't hear that anymore, and it's a nice feeling. It's like, oh, I finally unlocked the code on not having a patient come and tell me that they're on top of a street sign before they see it.
Yeah.
So so
Yeah. Go ahead, Joe.
no,
So
no, I think that's.
Go ahead. Sorry.
No, you go ahead. I was just
I was just
wrapping
going to
up.
ask then, so what are you with your IOL calculations? What's your target with the implant? So are you wanting them to be like a plus 50 hyperope before you do an adjustment, or what's?
I think the surgeon, I think, has recently changed that due to some data coming from our site, which I'm not fully on involved with yet, but I think he has been targeting slightly myopic now. And so my first treatment for the distance eye is typically an activation treatment because they're kind of usually sitting around plano to maybe plus a quarter when I see them at the 3 week. And I would usually blank treatment that or, my surgeons do a lot of LRIs. And so if I see astigmatism, I'm first looking at where the LRI is at and if it's matching up and making sense. If it's not making sense, I'm usually not going to correct the astigmatism at the beginning, especially if it's a half diopter. But a lot of times now I'm doing a very small treatment for the distance eye and aiming around plus a quarter, or just activating that lens and telling them to come back after the first adjustment. I like them to have more time getting used to the eyes being different. So I'll have them come back in about 2 to 4 weeks after the first treatment and just let things really settle down. We do some LRIs that are pretty large, trying to take away, 3 diopters of astigmatism in the cornea. And with the younger patients, it doesn't really work that well, right? So then you're going to have to achieve that with the LAL device, and sometimes that they're failing at different rates. So you're getting where you should have astigmatism returning at like 180, and it's at 140 or something. And usually you give it some time, it's going to probably just drift back to where it was at 180. And you just got to kind of be aware of those things happening. And so I'm always looking for those kind of things at the beginning.
Joe, that's a good point because I we do a number of LRIs and AKs depending on how much corneal still they have. So patients who have like two diopters or more typically will do a small LRI just to debulk it a little bit, which
Mhm.
the theory makes sense, right? You're going to leave yourself more macromers to work with. So let's say hypothetically we've got a patient with the rule astigmatism plus two diopters corneal at 90, and we're doing LRIs at the vertical axis. A lot of times, what I'll do if the patient comes in for their first treatment and we didn't get as much astigmatism with the LRIs as I thought we would, I will leave some of that on the table, assuming it will change over time. So treating just the sphere component, leaving
Mhm.
the astigmatism, or at least under treating the astigmatism, just because,
So
yeah.
I think I'm on the right page with that. If they do it, we work in minus SIL. I don't know, I know other surgery centers will work in plus SIL, but we work in minus SIL. And so when they're, doing the steep axis and doing the LRIs, we know that the if it's failing, it's coming back 90 degrees away.
Mhm.
And so if the incisions are as if they overcorrected, I'm definitely not going to correct the astigmatism because I'm kind of going to assume that they may fail a little bit. And I don't want to make that patient have more astigmatism the next time they come back if it continues to fail. Now, if I see it failing and I saw that preoperatively, this patient had about 2 diopters of corneal cyl, and I now see about minus 1.25 in that same direction, I'm going to probably correct the full minus 1.25, assuming that it's going to probably continue to fail, maybe whether it's my pressure on the cornea from doing these adjustments or so forth. But I'm assuming that it's going to get back to its more original shape prior to surgery. And that has seemed to work for me.
Yeah, I guess we're kind of on the same path. Either you assume that it's failing and it's going to go backwards, or you assume, I think what I've been assuming is that they will continue to change over time, which I've seen that. It depends on the architecture of the LRI or the AK, I think, and
Uh-huh.
maybe I'm a little bit ignorant to the specifics. Because what I have observed is, when we see them back at 3 weeks for their first adjustment, I don't always do an adjustment at that visit, but if I do,
Uh-huh.
generally I will do just the sphere, depending on where the patient's at. and how unhappy they are. If we're really off target, then sometimes it's nice to get the first one under your belt just to get them functional. Um, but I won't treat the sill. And generally, it has changed. So if
Mhm.
there's, like, let's say, a diopter of with the rule astigmatism, and I don't treat that, I just treat the spherical component, they'll come back a week or two later, and that one diopter has turned into a half.
Mhm.
It's change, which means, at least in theory, the LRI or AK is starting to work. The cornea is reshaping in the way that you want it to. It just is taking more time to get there.
Mhm.
But you're also right too, because I think if you flip the axis, then, well, that's concerning too. That's why we don't do. I mean, we debulk it. We don't try to treat all of it. We're pretty conservative with how much we're trying to get out of the cornea. Um,
Yeah, I have one surgeon that I think just is more aggressive than the other, and so you
yeah,
kind of have to know your surgeon a little bit too, and kind of see how they. And then I think I see the trends, and I think that there are different ways of doing an LRI, different tools to do the LRI to make it to where that you get that wedge to make it happen. So I think it will depend on knowing your surgeon to a degree. But I always have the assumption that my prescription is going to be off by a quarter of a stig, and then the treatment's going to be off by a quarter of a stig. So I want it to land on the right side of things. And it's going to
yeah,
always have that mindset, like it may not land right where I want it, and maybe my measurements are like a quarter off. And so if it's going to land on one side or the other, I want it to be on the this side of it, and I kind of just have that mentality.
yeah. You're totally right. I mean, there is some kicking into the wind here, and you also have to take into account how old your patient is. And
Mm-hmm.
the cornea is going to drift against the rule. I think what's the data? It's like a quarter every 10
Order.
years, right?
Yeah.
So if I can be hyperopic spherical equivalent with a little bit with the rule astigmatism in, like, a young patient, that's beautiful. That's gorgeous. That's
Mm-hmm.
what I want. If they're against the rule and they're young, I usually wouldn't mind flipping the axis just a little bit if I can, depending on if it makes sense to do that. Um, but yeah, no, and thinking critically about this, I mean, we're definitely aligned in the way we think about it. I think we all
So
are. I mean, you got to be critical with how you think about the astigmatism.
you just want to make sure that axis is, I think that's the most critical thing is you don't want to correct it at 40, 145, and then the next time you see them, it's at 180, and then you're chasing it around. That's what you want to try to avoid. I mean, that's what I want to try to avoid at all cost
Yeah.
is not chasing the astigmatism around.
I think it's important to get the astigmatism nailed on the first treatment. So I use the topographer pretty regularly on the first treatment
Mm-hmm.
just to see, because at that point, right, the theory is you've got the lenticular sill out, all you've got remaining is the corneal sill, and that's what you're treating. So if you can find where the axis is, your refractive axis, assuming the lens is central and it's not tilted, should be in line. So anything outside of, like, 5 degrees off, something's up. You've got a patient who's got dry eye, you've got a patient who's got residual corneal edema, you've got a gaping wound, something like that. Um, that's where I would take the foot off the gas again and just delay and make sure things make sense, because it should be right in line with that corneal steep axis.
Mm-hmm.
Well, guys, hey, we're coming up on like an hour right now. I mean, I don't have much more. If you guys, we'll probably do another one of these early in 2026. But yeah, I mean, keep the email chain going. If you got things that pop up, I think we could all learn more. This is a great chat. Appreciate all the input.
Thanks for the,
Happy holidays to everyone.
Thank
Yeah,
you.
Yeah.
this is recorded too, so we'll have it on the peer-to-peer website. You can pass it along anybody else that wants to watch this. Some valuable pearls here. So yeah, appreciate it, guys. Happy holidays. Happy New
Yep.
Year.
Happy
Yep.
holidays.
Bye.
Thanks,
Stay
everyone. All
safe.
right. Take care.
Bye.